Starting.
Hi, good evening. My name is Shirley Noel, and today the title of my journal club is on the effects of sitagliptin on the cardiovascular outcomes in type 2 diabetes. The funding of this study was by Mark Sharp and Dohan Corps. So here I'm going to give you a little background information. So to begin, dipeptidase 4 inhibitors are a class anti-diabetic agents that are used as a monotherapy and a combination with other agents for type 2 diabetes. Agents in this class includes sitagliptin, saxapentin, lignopentin, and agliopentin. This agent works by inhibiting the DPP4, which is the enzymes that break down GLP and GIP. DPP4 inhibitors basically enhance the function of GLP and GIP, which then increases the release of insulin and also decreases glucogen levels. DPP4 inhibitors haven't been studied much in regards to the effect of cardiovascular events. The trial evaluating cardiovascular event outcomes with sitagliptin studies was implemented for this reason. So the objectives of this study was basically to assess the long-term cardiovascular outcomes in the patients with histories of cardiovascular disease and type 2 diabetes, being treated with usual care adding sitagliptin versus placebo. The trial designs. It was randomized, double-blinded, placebo-controlled study. The location of the case study was given in 673 sites and 38 different countries. The IRB approval for this study was by the ethic committees at each of the participating trial sites. The inclusion. So basically they wanted patients who were 50 years and older, had to have type 2 diabetes, establish a cardiovascular disease, glycated hemoglobin levels of about 6.5 to 8.0%. The exclusion for the criteria for these patients, if they were taking a DPP4 inhibitor, a glucogen-like peptide 1 receptor agonist, or a TZD during the precedings of 3 months. Histories of 2 or more episodes of hypoglycemia during the preceding 12 months. Estimated glomerular filtration rates less than 30 ml per minute of body surface area at baseline, and unable to take sitagliptin. The subjects were a woman and a male. They were 50 years of age or greater. The primary endpoint. So the primary endpoint basically was the time of the first cardiovascular event, and the secondary endpoint was a death from any cause, hospitalization of heart failure, change in renal function over time, and initiation of additional anti-hyperglycemic agents or long-term insulin. Follow-ups. At baseline, it was about 4 months, 8 months, and then annually. The duration of the study was, it started on December 2008, and the study completion date was March 2015. The population consisted of 14,735 type diabetes with cardiovascular disease. The treatment arms included the experimental group, which added sitagliptin, and it had the placebo, which also added the placebo. And these basically had the same formulations that were used. The dosages formulations were basically the same for the experimental groups and the placebos, and there was like 50 milligrams to 100 milligrams by mouth QD. The statistical analysis basically consisted of Cox proportional hazards model, which was used to calculate the hazard ratios, and two-sided 95% confidence intervals. Power of 90% for tests of non-inferiority would require 601 patients with a confirmed primary composite of cardiovascular outcomes. Powers of 81% for superiority of sitagliptin over placebos would require 1,300 patients with a primary composite of cardiovascular outcomes. The baseline characteristics was measured using a median and an interquartile ranges. Relative risk was 1.3, as marginal upper boundaries was used to determine the non-inferiority of sitagliptin to placebos. A p-value was less than 0.001. The baseline characteristics. There were no significant difference in the baseline characteristics in the two study groups. Patients at baselines were similar with respect to demographic characteristics, using of anti-hyperglycemic agents and secondary use of cardiovascular preventions. At baselines, patients had a mean of glycated hemoglobin levels of 7.2 or a 0.5%, and had been living with the diabetes for a means of 11.6 or 8.1 years. The primary endpoint. There were no significant differences between the two groups and the time the first cardiovascular events. 839 patients in the sitagliptin groups had a primary cardiovascular event occur, and 851 patients in the placebo groups had a primary cardiovascular occur. The secondary endpoint. There was no significant and secondary cardiovascular outcomes, hospitalizations for heart failure, and death for any cause. 228 patients in sitagliptin groups and the 200 patients in the placebo groups were reported for hospitalization for heart failure, and 447 patients in the sitagliptin groups and 437 patients in the placebo groups were reported for death for any cause. Adverse events. So when you look at the chart on table 2 on page 10, which I emailed to you, you basically see that there were no significant difference in the rate of serious adverse events between the two studies. The author conclusion. The author concluded that using sitagliptin in addition to the usual care in patients with type 2 diabetes and cardiovascular disease, they did not see the risk of cardiovascular events, hospitalizations, heart failure, or other events. Also, it was concluded that sitagliptin can be used in diverse groups of any patient with type 2 diabetes who are at a higher risk for cardiovascular events. The strengths for this case study was basically randomized, double-blinded, controlled design, long follow-ups. Baseline characteristics were similar to the two study groups. Sufficient population withstand a power of 90%. 95.1% of the patients in sitagliptin groups and 94.1% in the placebo groups completed the study. The weaknesses